Good evening, everyone, and welcome to tonight's webinar from Can Do MS. We hope wherever you are staying safe and healthy, and we're thrilled that you could join us this evening. Tonight's topic is actually the first part of a two-part series here on symptom management. So we're going to be focusing on motor components and motor symptoms in MS. Thank you to our sponsors for your support of this project. And thank you to our partners, the National MS Society and the MS Society of Canada. With that housekeeping out of the way, we have two wonderful speakers this evening, and they are both physical therapists with many years of experience with multiple sclerosis. We have Jennifer Keller from the Kennedy Kreiger Center in Baltimore, and we have Sue Kushner from Slippery Rock University in Pennsylvania. So I will let them introduce themselves a little bit more, and we'll start with Jennifer. Thank you for being here so much. Welcome.
Thank you, Brian. Thank you very much for having me here with you guys today. I'm looking forward to talking with you with Sue about motor symptoms in MS. I've been a physical therapist for about 20 years now. I work in a movement studies laboratory where we look at how to best measure motor and sensory impairments in people, as well as movement. And we do that in order to see if we can better quantify symptoms, as well as measure progression of disease, and also to measure the effectiveness of our interventions. So I'm looking forward to telling you a little bit more about that today and to be presenting with Sue.
Hello, everybody, far and wide. I'm happy to be here. I thank Can Do, and I've enjoyed working with Jennifer, and I'm a physical therapist for about 35 years. I'm on faculty at a small school outside of Pittsburgh, Pennsylvania, Slippery Rock University. I have done work with Can Do MS for 32 years, I believe. I'm a clinician and treat all types of patients, and also teach in the physical therapy program, Graduate School of Physical Therapy at Slippery Rock University. And just very happy to be here with everybody far and wide over the country and possibly other places too. And I know we're talking to Brian in Colorado. They got snow in the mountains, and it's in the 90s on the East Coast. So if you're on the East Coast, stay inside. So we will get started, and like we said, we will leave time for questions. We're happy to answer what we can. And as you see on the first slide, our objectives tonight are to help define weakness, spasticity, and tremors with you and how they affect you and your MS. Identifying some challenges to your movement and related to weakness, spasticity, and tremor, and differentiating between these three common symptoms. And then everybody likes to be very practical. That's mostly what you're here for, is for you to learn what you can do to help manage those symptoms. So we will finish up with that. So hope you enjoy it.
So a lot happens when we want to make a movement. We need motor commands to be sent down to the body, but we also need some feedback information about whether or not those commands achieved what our desired goal was. And it's a complicated process that in health, our bodies do remarkably well with flexibility. For instance, if we want to walk over a level surface, that might not require a lot of our awareness, but if we want to go up and down stairs, or we want to walk on the beach, things become more complicated. And when there are impairments in the system, that doesn't mean that our movements are always as successful.
So MS symptoms affect how we move. There are many, many types of symptoms and huge degrees of variation of the way MS affects people physically. So some of the impairments are walking, problems with transfers, upper and lower extremity coordination, problems with trunk control, and these are all overlaid with problems of spasticity and weakness. And it's very important for us as clinicians to help differentiate for you and with you some of these differences, particularly between spasticity and weakness.
So because there are so many different symptoms and most of them can affect how we move in MS, we see that walking is very variable in MS. So I'm going to show you a few videos now just to see how different people with MS might walk. Everyone's walking as quickly as they can. In that fast video, you can see that she doesn't seem to have many changes to her walking. She walks quickly with ease, but you can see with this gentleman, as he tries to walk quickly, there's still they walk more slowly. And then in the next slide, I'm going to show you 3 different people walking who have a hemiparesis. That's kind of a big word, but it really just means one side of the body is affected with probably both motor and sensory changes. And while all 3 of these people have that same set of symptoms, their walking looks different. They may take a larger step on one side than the other. They may take a quicker step with one side or the other, or they may show just some not smoothness of their movement as they swing through their leg. They all sort of, I guess we tend to think, look a little bit like limping. And then we also want to look at someone with spasticity. Their gait is most often described as stiffer and maybe more abrupt. And then someone with ataxia, which tonight we're really talking, as we talk about, as tremor, but you'll see there's more imbalance and difficulty putting their feet where they want them to go. It's really important for us to be able to distinguish between these symptoms for spasticity, weakness, tremor, or the others, because it helps us to understand better why a movement doesn't occur that we want to occur. And then also it helps us as therapists and your rehab professionals to select the optimal treatment for these symptoms. So weakness, there's obviously strengthening. Spasticity, there's often medications and stretching. And for tremor, which is often a little more challenging to treat, people find, but we can find that there are good strategies to use, such as slowing down a movement or simplifying a movement. And we're going to talk to you about these in a little bit more detail tonight.
So as we mentioned, some of the objectives, defining weakness, spasticity, and tremor is what we will move on to next. So what is weakness? It's just basically described as a lack of muscle strength, but we need to know why you have the weakness and where specifically the weaknesses lie within the body. A primary reason could come from changes from in the nerve stimulus to the muscle. The message just is not getting from point A to B to tell the body, to tell the limb, to tell the foot, whatever, how to move. And this may be from lesions in the brain and the spinal cord, depending on your specific type of MS. A secondary type of weakness is disuse atrophy. I think everybody has heard the saying, you know, use it or lose it. So if you're a couch potato, through this COVID time, some people have gotten in better shape. Some people have really lost it because of spending too much time sitting, not getting out, and not moving. So if it's secondary or disuse atrophy from deconditioning, we're going to work at it and approach your problems differently than if we find that it is a motor control problem from the nerve conduction. And secondary disuse can also be from changes in how one moves, reducing specific muscle activity. And you wonder, like, how does this weakness feel? And most of you will know it's of fatigue, and fatigue is one of the biggest problems with MS. People also describe it as a heaviness in the limbs or even overall heaviness in the body.
So how do we measure strength or weakness? In the clinic, as you can see on the right, everybody's had a doctor or therapist push on your leg or your arm to see how strong you are. And when we do that, we usually use a rating scale from 1 to 5 to say, 1, maybe there's a twitch of the muscle, to 5, there's no change, strength is normal, you're strong. In the lab, we like to use something that gives us more of a number. So in the picture on the left, you can see that this physician is holding a dynamometer, we call it, and it when we resist against that instrument, we get a reading in pounds of how strong that muscle is. So in both of these photos, we're actually testing the hip flexor muscle, which pulls your knee towards your chest. And we think it's really important because it's important in walking, and particularly in MS. But what I find helpful about using something like this instrument is that whereas I might rate the person on the right with a 5 out of 5 strength, on the left, I might know that the strength is 45 pounds on one side and 38 pounds on the other side. And that gives me a little bit more information about asymmetry between strength or just weakness relative to other people the same age, and that can help me better target a treatment. Spasticity is it's a little more difficult to explain. It's dependent on speed. And it's also dependent on it's when someone else moves you. So if you're gonna try, rather than moving my arm up and down, it's someone moving my arm for me. And if I move slowly, I might move smoothly through the whole range, and that would be no spasticity. But if I move faster, then I might feel a catch, or I might feel more stiffness. It might happen at a certain point in the range where there's a catch, but then it keeps moving. People often describe it as a tightness or a stiffness and difficulty to move fast, so that if you try and move faster, you get a jerk to your muscle, you're just stopped. We tend to think about it. It can even go from, a normal movement all the way up to a rigid posture. So you might not even be able to move at all. It might become that stiff. If we look at this picture on the left, it's showing you along the bottom line how fast someone would be moving. So at the corner would be not moving at all. To the far right would be moving as quickly as possible. And then on the vertical axis, you can see the arrow pointing up saying increasing force. That's how much resistance the muscle is giving against that movement of speed. And if someone doesn't have any spasticity, it's going to look like the brown line, the control line that goes straight across. There's no change in the amount of stiffness or force that you feel when trying to move someone's limb for them. However, with someone with spasticity, you might be able to move nice and smoothly at the bottom of that blue line on the left. But as you move them faster along the line, it's going to get harder and harder to move. Let's see, I guess it's just a more complicated thing for us to as clinicians to measure. Okay, so go ahead, Sue.
So the relationships between weakness and spasticity are intertwined and a little bit codependent, but also highly, highly variable person to person, and in fact, day to day, week to week with the same person. So in general, spasticity, you would normally put it in the negative column. It's a nuisance. It can be really negatively affecting your ability to move. It can sometimes cause you pain. But spasticity can actually assist you up to a point with weak muscle groups. So what I mean by that is your thigh muscles are your quadriceps. If your quadriceps are so weak that you have trouble standing up straight and locking the knee, you're not going to be able to do transfers very well. You may not be able to be ambulatory or not walk well. But if you have some spasticity in some lower extremity muscle groups, this may actually help you when the spasticity kicks in to be able to stand straighter. So that's why when the physician, when your neurologist is playing with the medications that you are on, you have to let your physical therapist and your whole healthcare team and the physician know, is the baclofen or whatever you are on, is it helping your spasticity, or is it taking all of your spasticity away to the point that you are not able to stand? So you may want to keep some of that spasticity to help you with functional movement. So if the muscles are very weak, some increase in tone can help. And I mentioned the quadriceps, your thigh muscles. Those are your extensor muscles. Something like your hamstrings that are behind your knees. Those are the flexors. So again, too much spasticity in the flexors does not allow you to straighten your leg because the hamstrings are pulling your knee into a bent position. But again, if you have some spasticity in the quads, that'll combat it, and you can stand, transfer, walk, etc. Adding to weakness is just the chronic problem with fatigue. It's always described as the most common, the most annoying symptom related to MS. So we as healthcare professionals want to determine how much of your muscle weakness is due to true weakness versus spasticity. And keep in mind, like I said, spasticity can be mostly negative, but with some positives. But you have to keep in mind that prolonged spasticity, if your elbow is always bent, if your knee is always bent, that's going to result in some permanent, potentially permanent muscle shortening, and it may result in contractures, which are very difficult to deal with and can be very painful also. Then we've mentioned tremors, and so you may experience tremors, you may not, and not even be sure what they are. Basically, it's described simply as a lack of control with voluntary movement. You have a lack of coordination throughout the movement, or this is obviously not a medical term, but your movements may be like herky-jerky. They're just not as smooth as they should be. Tremors are seen a little bit more often in the upper extremities and related to fine motor skills. And when you think of what you need fine motor skills to do in daily living, it's the eating, it's writing, it's using the computer, hygiene, dressing, putting makeup on, fixing your hair, buttoning your children's shirts, or tying their tennis shoes. If the trunk or lower extremities are involved, this may cause you great difficulty with walking. It may affect your transfers, getting in and out of a car, and maybe even just sitting comfortably for prolonged periods of time. And once again, because there's a lot of unnecessary muscle involvement, muscle movement, this can add to your already pre-existing large amounts of fatigue.
Yeah, so tremor can be a hard thing to know just by hearing about it, but seeing it makes it much more obvious. So here you can see this gentleman, he has a large swerve to his movement as he's reaching for my finger, and as he gets closer to the target, you can see it's a lot more like jerky, I guess is a good way, that kind of overshoots or undershoots his chin as well as my fingertip. And we kind of look for what the smoothness is and whether or not someone is able to hit the target that they're aiming for. When we want to measure this, we look at someone's reaching to a target, and we look at how that path of the movement goes. So on the next slide, we have a person in the upper corner reaching for a target. You can see they're sitting down and their arm is free and they can reach up to the target. And what we want to look at, what I'm showing you in the lines and the graphs below, the lines show you how the wrist is moving on that path, on that trajectory. And then the dots, they show you where the fingertip gets to, and this open circle is the target that that person is reaching for. And what we want to do is look at the smoothness of the movement. So if we look at the black lines on the left of someone who doesn't have a tremor, you can see that they're pretty smooth towards the target, and they overlap each other very consistently one on top of the other. In comparison to the person with tremor on the right, if you look at the red lines, you can see how there's a curve to the movement. And each movement doesn't look the same. They're not necessarily, it's not the same every time. And then also you can see how the end point where the finger gets to doesn't consistently end up at the same point. It's kind of all over the place, missing the target. So those are two important features of tremor that we look at in order to help us better assess what people's reaching is like, or their movements are like, and how their tremor is impacting how they move. Next, we want to define for you a little bit more about what motor challenges you might have from spasticity, weakness, and tremor. I think.
So what is the definition of motor control? We as therapists like to break it down into gross motor skills, and that involves larger muscle groups, and then fine motor skills. I already touched upon the fine motor skills, so I'll start with that. The muscles, the smaller joints, smaller muscles used again for writing, using feeding utensils, precise movements. And again, we think more of upper extremity movements with that. And like Jen had that terrific slide, the one before this, about how erratic the movements can be with a tremor. So imagine a hot cup of coffee or tea you're trying to control, to have it first thing in the morning, and how difficult and even dangerous that can be with the jerky type movements. Then gross motor or larger muscle movements are involved more with the lower extremities, but you can also think of your bicep, just the bending of the elbow. That would be a gross motor movement. I mentioned those quadriceps already, the front thigh muscles that help to straighten your leg. A lot of the hip and buttock, the gluteal muscles that are involved with going from sit to stand and stand to sit. And you need strength and power for going from sit to stand. You need control going from stand to sit. And then again, these gross muscles are involved in the walking and transfer skills that we need every day to remain mobile. And then some challenges in motor control from the three symptoms that we have been talking about. You may lose some range of motion. And again, that's that shortening, not always resulting in a contracture, but it may be a shortening of a joint's ability to move. So an example would be if you don't have full motion in your hip. So when you're walking, if you have some tightness in the front of your hip, in your hip flexors, you're not going to be able to take a normal step. You're not going to be able to get that hip to extend behind you. And in gait, that's when we get the ability to push off. And so your gait is going to be quite abnormal. It may be to the point that it's very uncoordinated, sometimes even dangerous. Worst case scenario may result in a fall. Problems that may occur in the knee. You might have a lack of full knee extension, which I mentioned already, if the back leg muscles, your hamstrings, are very tight. So if you're walking with your knees bent a few degrees or 15 degrees with every step, imagine how fatiguing that is, step after step, day after day. Again, can result in some lack of coordination, potential falls, and goodness knows, you want to avoid falls at all costs. I don't like to scare people, but if they are hesitant about using, say, an assistive device that I might recommend, I say, you know what, you do not want to fall. Worst case scenario, you may sustain some sort of fracture. may or may not need some sort of surgery with pins and plates and casting and immobility. And then, you know, you're in a cast or something for 4, 6, or 10 weeks. You come out of that, you're weak, you need more rehab. So I'm giving the worst case scenario, but sometimes that's what you need to hear just to err on the side of being safe and cautious. Other challenges from the symptoms that we have been talking about are problems with coordination, just lack of smooth ability to move. These may result in balance issues. And again, net result is adding to your already existing, possibly overwhelming fatigue. And balance issues, we'll touch on that a little bit more. They can be so detrimental with resulting falls. And then range of motion loss, I mentioned it already with the hip and the knee. You also may have some experience in loss of range of motion in the foot and ankle. And again, when you're thinking about walking, the foot and ankle move, the knee moves, the hip moves, your back moves, everything builds from the ground up. If your problem is starting where your body makes contact with the ground, which would be the foot and ankle movement, you are going to have problems everywhere above that joint. So the knee, the hip, the back, everything. So loss of range of motion in any joint, again, can be due to long-term results from spasticity, which I mentioned, and a shortening of a joint's range of motion, potential contracture. Can also be due to a long-term result of plain old weakness. And then I already mentioned some balance impairments. Your foot becomes less able to adapt to its surroundings. So if you're on ice, you may not be able to catch yourself like you normally would. If you're outside in the yard now in nice weather and you hit a little stone the size of a fist, boom, that may just throw you to the ground quickly because your foot, ankle, and everything above it does not adapt as quickly as it used to. And again, frequent falls, loss of balance, big problems we need to avoid. And then I've mentioned walking, which we also call gait, frequent trips. You have to make sure that the toe clears. If your toe does not clear, that it may be due to you not having the hip strength to lift the leg high enough. But again, a resulting fall is what you want to avoid at all costs. And then stairs, you know, life has stairs, life has hills, life has bumps and curbs and uneven sidewalks. So again, gait is, you know, a big concern with problems with loss of range of motion. And then we move on to the last objective, exploring practical strategies on how to manage a lot of these motor symptoms that we have talked about and can become problematic.
So I like this way of thinking about it, but how we can make our lives easier, I think that's most important, and what things you can change in order to do that. You might be able to change something about yourself, or you might be able to change something about the strategy that we use, or you might be able to change something about your environment, or in like the case of this pandemic, the environment might have been changed on you. You may be stuck in one place and have less choices of where you can move. You know, I think as therapists, we often think mostly about what you can change about yourself. That makes us start to think about balance exercises, endurance and strength training. Whatever it is that you find that gets you moving is probably the most important thing. But also finding which areas, as we're talking about today, which areas it is that you most need to target in order to improve the things that are your weaknesses. So one way in which you can do that about the symptoms that we're talking about is through strength training for weakness. In the next slide, I just want to talk a little bit about a study that we did. We had people with MS exercise their hip muscles in particular to strengthen them. 3 times a week they came to the lab and they did resistance exercises with exercise bands, and they did it for 12 weeks. And what I wanted to show you in this graph on the left here is that on the vertical axis, you can see the big arrow. It says increase in strength. So the higher up it is, the bigger the strength. And then along the horizontal axis where you can see the 1, the 4, the 8, and the 12, that's how many weeks into the program they are. So at the beginning of the exercise program at 1, they're at around 330, which is just it's not an important number. It's just that that's where they started at. Probably most of their strength, from what I told you about their hip flexors, was like 20 pounds of resistance, let's say. And then at 4 weeks, they were a little bit stronger, but at 8 weeks is when our statistics told us that people were actually significantly stronger. And this is a really important finding because everyone said that it would really take 12 weeks. And I think it's really nice to know that if you're going to put in that time and that effort to work, that you might be able to start to see a benefit at 8 weeks. But likewise, in the reverse, if you don't want to give up at 6 weeks, because if you just put in those 2 extra weeks, that's when you might start to see an improvement in your strength. And people in this program, they said that they found things changed, such as like being able to go up and down stairs more easily. They didn't have to hold onto the railing so much and pull themselves up. They found that they could walk farther before they were, tired and needed to rest. Things that they, found surprising from mostly 5 basic exercises in resistance, but they worked hard. They made the intensity so that it was on a scale of like 0 to 10, it was at least 50% of their maximum effort of what they could do. The other nice thing that we found from this program, because it was specific to each muscle, so the muscle that pulls your knee towards your chest, the muscle that moves your leg out to the side, the muscle, your glutes in particular, the ones that we all sort of seem to forget to look at, but they're the ones that are most important to get us out of a chair, to make us walk quickly, to get on and off of the floor. If you don't strengthen these in a specific manner, so that you're making that specific muscle stronger, it's easy to compensate. So if you think about the leg press at the gym, if you push out with both legs at the same time, if one leg is stronger than the other, then the stronger leg tends to get stronger and the weaker leg doesn't always get stronger as well if you don't pay attention. You can also use other muscles, because not only the quads are working or the glutes, but you have also their calf muscles working. So those can compensate for each other. So if you'll just advance to the next graph, it just shows here that the hip flexors in this person, one side was a lot weaker at the beginning. The black was their left, but at the end of the study, both sides got stronger, even though they didn't both become the same strength. Whereas in their hip abduction muscle, in the next one, you can see that we actually were able to improve the left side so that it became comparable to the right side. And so that might be an evidence of one of those like secondary weaknesses that Sue talked about at the beginning, where say you have pain in your ankle and you start limping for a while, and once the pain goes away, you're still limping just because you've become used to that habit and those muscles have become weaker. And that's something that could easily be addressed through strengthening in something like this sort of a program. But there's more than just strengthening to a good exercise program that would address your needs. I think Sue is going to talk about flexibility for you now.
We all need to remain flexible. This is keeping your joints to as full of range of motion as possible. I think everybody knows what a tight low back feels like. Everybody knows what tight hamstrings, your back leg muscles, feel like. To have the best chance for proper movement, balance, and coordination, you need maximum flexibility that joint is going to allow you. So, excuse me. So we want to have you work on stretching, and stretching is one of the activities I recommend for people to do daily. You don't necessarily need to do strengthening every day or cardiovascular exercises every day, but stretching and maintaining flexibility is definitely worth doing every day. You want to do stretching in smooth, prolonged movements. Some ideas are yoga, and you just think, oh, you know, I cannot do yoga. I've never done it. I'm not that coordinated. There are so many types of yoga for every ability level, every level of experience, every type of enjoyment. If you want to go fast, if you want strengthening yoga, it's out there. If you want yoga in a chair or only on the mat, there's that type of yoga. The best thing to do is explore the different types of yoga and find out what might work best for you, and that includes what type of instructor is best for you. Can you get to a place now that things are opening up, or do you do better just tuning in on your phone, on something online that will work for you? In addition to flexibility, in addition to yoga, there's Tai Chi, there's so many different types of activities, and sometimes try and get away from the word exercise. Think of things as activities that you like to do and are enjoyable, and there's an entire gamut out there that we as therapists can help you find. Next slide. Also, I've mentioned a few times balance and coordination. Again, you need a proper evaluation so that you will know, is your problem with balance and or coordination, is it from weakness? Is it from spasticity? If it is weakness, which type of weakness of the types that I have mentioned? Is it a sensory problem? Do you just not know where your foot is in space when you're walking without looking down at it? So that's why you need a proper evaluation from a PT and or OT. And then again, we need to help you incorporate exercises and activities into your daily routine. I already mentioned yoga, Tai Chi. A Swiss ball or physio ball is the big ball on the left-hand side of the screen. You wouldn't believe how many things you can do with those and how fun and enjoyable it can be. I love to preach the benefits of aquatic activities for people when pools are open. You need not be a great swimmer. You don't even need to know how to swim, but you can go in, you can be buoyant, you can move in the water with way more freedom than you maybe could ever have moved on land. All kind of little inexpensive gadgets to help you. Those noodles you can get at anywhere for a couple bucks. A buoyancy vest can help you move. You can walk in the water. You can walk backwards. You can walk sideways. You can do exercises where the water acts as a great resistance. So it's almost like having weights on your body. I always bring this example up. Years ago, I had a patient that said she wished she could spend her life in 3 feet of water in her house, outside, everywhere, because she was able to be upright, mobile, and move with freedom that she could not move with on land. So aquatic activities are wonderful. Make sure the water isn't too warm.
So if you want, I can.
Yeah, go ahead.
That's fine. Yeah, so I think we both, I think this kind of takes us a little bit back to the flexibility part as well. So for spasticity in particular, there's a number of medications that are used. You've probably heard of baclofen or Botox. But if a joint has lost range of motion in particular, then sometimes it's difficult to get it just through simple stretching on a daily basis, because say you spend all night with your foot pointed downward when you're sleeping, you just really can't get a good stretch as long as you need to. So often rehabilitation or neurologists, physicians will want to use Botox, which is acts directly at the nerve endings where they meet the muscle, and it sort of deadens them. I won't be the person that best describes that to you. That's something that I would leave for your physician. But it works best, we find, in conjunction with splinting or casting. And so where you would get the injection and then you would be casted at the best range of motion that you have. And then over the course of a week, the muscle lengthens because it sits in that stretched position. And so at the end of a week, we can change the cast or the splint to make it stretch even further. And that usually is necessary for somewhere between 3 and 6 weeks, depending on how tight someone is. And then usually splinting continues after that for a longer period of time. I think that that this technique can be extremely beneficial to help regain that range of motion that you really need in order to, say, put your foot flat on the floor in order to stand for a transfer or to walk and not catch your toe. But it's something that you should discuss well with your providers, because it's not simple to be in a cast for that time. That's going to change what you're able to do over that period of time. But you also want to get the most benefit from any sort of intervention that you try. Beyond this, we also wanted to talk to you a little bit more about tremor. That's fine. Tremor, I'm going to talk to you in particular today about mostly in reaching in particular, because that's how we measure it and in the lab and talk about it, but it can affect your legs as well. And it usually also can be a indication that balance might be impaired. So focusing on balance as well when people have tremors. But 3 ways in particular we've been finding are most helpful to address tremor. So slowing down your movements, reducing your movements to just moving at one joint at a time if it's a motion that requires your whole arm. And then also it's been a sort of a on again, off again treatment that therapists have used for a long time to weight a limb to help with movements. And we found that now that not weighting is actually beneficial, but there might be a reason why people think that weighting is helpful. So in the next slide, I'm going to talk to you a little bit about slowing down your motion. So you might remember that I showed you this figure where someone was reaching for the ball, and originally I showed you on the right side, the fast motion, so people are moving as quickly as possible, and you can see how uncoordinated the movement, how variable it is, how it doesn't overlap itself, and how the endpoints, little black dots, miss the target. But on the left, you can see the paths of the wrists, that they overlap a lot better, and that the endpoints are all closer to the same place. And this comes from the person being able to move just more slowly to that target rather than moving more quickly. And so that's pretty simple, and something you can do today to be more successful in your movements is just to slow down and take it a little bit slower. The next way you can reduce tremor that I was going to talk about is reducing it to a single joint. So these little comic characters, you can see that the gentleman in the top figure, his arm is resting on an armrest. And so we have them keep that elbow on the armrest and just bend the elbow up so that they can get to the target. So the green is the starting point and the red is the ending point. And you can see someone reaching with the tremor on the right in the graph. So say the X, the center of those lines, is the target that they wanted to reach to, the red dot. You can see that most of them meet the red dot. There's some that go beyond, but generally they meet the target. In comparison to the little comic figure on the bottom below, you can see that we've taken away the armrest so that he's no longer resting his arm, and he can move at the shoulder and the elbow at the same time to reach for that target. And when we look at the graph on the right that goes along with that motion, you can just see how much more it is all over the place, both undershooting, so not getting to the target, and overshooting, going beyond the target. This is kind of an important feature because one ways you might do something like that is, say you wanted to reach for your cup while you're eating dinner. If you just rest your elbow on the tabletop and simply straighten your arm out to your glass, you'll be much more successful at reaching it rather than knocking it over. And then grabbing it and bringing it to your mouth in the same way can get a lot easier. This is sort of how bracing works. So some people may wear a brace on their wrist, and then that way they don't have to control their wrist motion when they're trying to write or reach for that glass in addition to their elbow and their shoulder. It's also how it works when we think about putting a brace on the ankle. Sometimes you might not have a lack of range of motion or a lack of strength, or even have spasticity, but we might, as therapists, recommend trying it, because if you don't have to control that ankle and you just have to control your standing from the knee or from the hip, then that might make you more successful at your balance or at your stepping when you're walking. And then lastly, about weighting. So I'll show you, there's a little picture of a guy who is reaching from a green dot in the center out to points along a clock, so just around the clock axis. And when we have someone reaching who has a tremor, you can see that the reach is in the diagram to the right. These are just the paths that the finger traveled trying to get to those targets. Again, they're variable, they have a curve to them, and they don't really always meet the target. Sometimes they go past it and then come back again. So we have a cool robot that we can specifically add tiny increments of weight both to the forearm and to the upper arm, and we determined what would make each section of the limb do the best reach, and we added those weights onto the same person, and you can see that we actually didn't make them better. In some cases we made them worse. And so even with our ability to finely tune those weights, we weren't able to improve reaching motions with weighting, which makes me think that me in the clinic, even though I might want to try a weight on someone's wrist, I'm really probably not going to be able to find something that's that effective. And so we think that not weighting is best because in doing so, it doesn't make you more coordinated. However, what weighting might be showing us in the clinic is that it encourages you to move more slowly. And so because we've seen people move more slowly, we were thinking that weighting was helpful. But instead that focusing more on the slowing down your movement will make it more accurate. And that leads us to safety.
And so you want to just think about what you can do for your environment. And some of the things are very common sense, but you may overlook them or just not think about them. So think about proper footwear. You want shoes that are going to work well for you. Some folks like a nice flat leather soled shoe. Other people find that they're likely to slip in those. It's not enough traction. Other people like a running type tennis shoe, you know, with the big treads. Other people may find that that will cause them to trip. You want to keep your floors clear of junk, of throw rugs. Think about your floor coverings, your indoor outdoor carpet, wood. You should not have shag carpeting. Not only is it dangerous, it's very out of style, although I think it's coming back into style, but just, give some thought to the traffic flow in your living spaces, in your working spaces, getting to your car in your garage. Is there a bunch of junk there, or is it a nice clear space? And then think about proper assistive devices. Certainly a therapist may need to assist you with this, the proper type of bracing, the appropriate walker, cane, forearm crutches, an electric wheelchair, or an Amiga. So look to us to help you find what is needed for your assistive device arena. And then what strategies can you change and work to do so?
Like we talked about, you can move more slowly, and you can simplify your movements. So don't try and do too many things at once. For instance, when you're coming to standing to, you want to make sure that you wait a few seconds to make sure that you're stable. And then once you're stable, you want to come to a stop and see how you feel before you take that first step. It's important to just do one thing at a time and not multitask. So a lot of us are trying to walk and talk on our cell phones or answer texts, and that can be such a quick mistake that can cause us to trip or to fall. And it's really important to give yourself permission to accept help. So, you know, if someone else can take that hot dish out of the oven for you, you know, ask them to do that for you. If it saves you some energy to be able to do something that you want to do, like go play with your kids or have a chance to exercise, it's important to make those choices for yourself. So there's also, I think we talked a little bit about things you can change about your environment, like not having throw rugs. You can also choose the right appropriate assistive device. And talking about this, Sue and I probably each have our assistive devices that we go to often, but there's hiking sticks, which lots of people use to be outside more. There are these walkers that will go behind you. And in particular for people with tremor, I like them because you don't kick the wheels as much as a front rolling walker. I always want to try this Trionic one out. It's supposed to be really cool. It goes up and down curbs and you can get out in nature a lot better, but I haven't splurged yet on the expense for one of those. The Nitro has gotten some good popularity and I see that around a lot. It's a little bit heavier, so it sometimes can help with your balance, but it makes it harder to get it in and out of the car. So sometimes having more than one is a good option. There are people that need to try and stand up taller or can't use their hands as well. You can rest your elbows and walk. And then there are other walkers that can give you more stability as well, such as the U-Step. And there's a large variety of canes, and I will never forget a gentleman who taught me, I'm not a very good golfer, but he taught me that the putter is a great example for the height that your golf club or that your cane should be. So for your golfers out there, if you just turn your putter upside down, that should be about the right height for your cane. And I guess I don't know, sorry, you want to make your environment safe. So choose the right chair to sit in. You know, at the end of the day, you don't want to sit in that comfy couch that you might have a hard time getting out of when you need to take a trip to the bathroom. And use a firmer chair that you know you'll be able to get out of if there's not someone around who can also help you if you needed it. And then looking out for power cords that might be in your way, using lights to light your path at night so you can use your vision to help you. And then there's a lot of assistive grab bars out there and handrails. A good occupational therapist can help you pick out the right things for you to make your bathrooms, where a lot of dangerous falls occur, safer and less and more successful. And then technology, there's so much out there. Here we have 3 things for you. There's this cool liftware level that can, if you have a tremor, it can balance out your tremor and help you be able to feed yourself. It'd be nice to have a Roomba vacuum or one of those remote vacuums that could vacuum while you're out doing other things. And vacuuming can be so tiring, so it's a good thing that can help you conserve your energy as well. And then using smart lighting. I remember the clapper, but you used to be able to clap and make it turn on and off the lights. But there's more things you can turn on and off the lights now when you're not even home if you want to, with things like the Google Home system or Alexa. So so don't forget that there's that technology out there that can help you. Let's see. So we're all virtual now, at least for a while still. I do a lot of Zoom therapy these days. And so if you want to find somebody near you, you can go to the American Physical Therapy Association website, apta.org. And if you look for the Find a PT link, it will take you to a search where you can put in where you live, and you can ask for a neurological specialist, and you can specifically try and find someone who knows something about MS, because that's so important to get the therapy that you need. And you can contact them to see what virtual or web-based PT right now is offered, and later in person again, we hope. I always want to thank all of the participants in our studies at the Movement Studies Center Lab, because without you, we wouldn't be able to have good research into what works. And I also provide a list of references for you. We just like to have you be able to have those. You might not want to go there for more reading, but you might want to take those or give those references to your provider so that they might look into more information if they need some ideas for how to help you best. Thank you, Brian and Sue, for
Thank you.
letting me join you today.
Thank you so much, Jen and Sue, for all that great information, some background knowledge on some really common and frustrating symptoms. And so hopefully you all gain some insights and maybe some strategies and resources. And you will receive a PDF copy of tonight's slides, so you can print them out and go back to them as a resource. We have about 15 minutes for some questions, and we've been getting questions through that questions panel throughout the evening, and we also got some during registration. So we're going to get to as many as we can, and if we don't get to your question, that is okay. We'll tell you about another opportunity that you can submit questions to Can Do MS, so we can get you as much information as possible. So as we wait for those questions to come in, I do want to let you all know that you will get a survey at the end of tonight's presentation. If you could try to fill it out as specifically as possible of what information you found useful, what you wish we would have talked about, or what we could have done better, that makes these webinars more and more effective and more engaging and empowering. So that will be coming to you when you sign up this evening. So we do have questions coming in. I want to start with Jen. You mentioned the baclofen pump. Could you talk a little bit more about how that works with managing some of these symptoms? And what's your opinion of that compared to some of those other treatment options that you were referencing?
Well, okay, the baclofen pump, it's a lot. So I talk about baclofen. You can get baclofen. Physicians can prescribe and talk to you more about it, but there's a way of getting it just orally as a medication. But the other way that they can administer it is directly to the spinal cord, so that it gets targeted more to where you need it, and you need smaller doses. However, it's invasive, so it requires a surgery to put in a pump and then a line to the spinal column, and it requires regular maintenance and filling. So so it can be more make you more, restricted in what you can do in terms of you have to be able to be available for your doctor's appointments and make those on a regular basis to get that. Usually it takes there's a big full evaluation beforehand in order to see if it might benefit you, and then as well they usually do like kind of a test procedure in the hospital to see if it's beneficial before they actually put in the baclofen pump. But it is, I guess, has the benefit to you that it's a lower dose of medication and might be able to be more effective, and it can last for a long time. So if things worsen over time, you can increase the dose, or a physician can go up and down and work with you in order to do that. Our physicians are, one of mine in particular I work with, he likes to adjust and not tell me as a therapist, and see if I can tell if it helps or not as well, not just the person, so that we can kind of work together to see if there's real change or if it's more of something that we just feel is beneficial.
Great, thanks, Jen. Sue, you were talking about fatigue and how exercising can be a way to manage that really common and debilitating symptom. But we have this one viewer that says exercise kills them for the rest of the day, even walking, and they're out of commission for the rest of the day. So how do you balance the need to get exercise and to walk, but then to still have a life and not be totally fatigued at the end?
You have to exercise. Everybody has to exercise. There's no getting around that. What a person who, somebody like the person who asked the question is, they have to find what's going to work for them that may be a little bit tiring, but not totally wipe you out for the rest of the day. There's a lot of different strategies that your therapist may be able to recommend for you. Some may include small increments of exercise throughout the day, maybe 2 or 3 bouts of 10 minutes each. You need to really play with the time of day that exercise works best for you. Most people with MS find the overwhelming fatigue late afternoon, early evening, probably not a great time to go at it full speed. Some people do better first thing in the morning, or again, 10 minutes in the morning, 15 minutes at lunch, and that's it. In this type of weather that we're coming into with, hot, humid summers, you have to think about the environment in which you're working out also. Everybody exercising with MS needs to stay cool, needs to stay hydrated. Most every person with MS will have some negative effect with increasing body heat. So you want to stay cool, you want to be hydrated, you want to have a fan on you, maybe a cool compress around your neck. They make vests that have cool water to flow through them. I already mentioned how much I like aquatic exercises, and the water is wonderful to cool your body off, keep the core body temperature cooled the rest of the day after you've been in a swimming pool. So you just need to find the variety of factors that I had mentioned to work for you. And it's going to take some experimenting for some people. And also listen to your body. If there is a day that you are so wiped out, you feel like you have cement coursing through your veins and your brain, take that day off.
That's great
also
advice.
like to add to that. I think we all experience like weekend warrior syndrome, where you really want to get exercising, and so you just jump right in and you do it like way too much more than you should. And so sometimes I think another strategy that people can use is just to start backing off and start slow, and then see if they can keep adding to that, rather than going in and being disappointed that you have that muscle soreness or the fatigue that comes from that enthusiasm, like you leave here tonight and you really want to go exercise. All right. So
Absolutely. Jen, you talk a lot about tremors, and we've had a couple writers talking about tremors in their jaw specifically. Is that kind of a common thing that you see? And they're really concerned about chipping teeth and sort of the ramifications of that. So is there any sort of specific tips you could give to people with jaw tremors that you've seen?
I'm afraid I haven't personally worked with people with jaw tremors for treatment. I have seen people with that. I think that there are some good therapists that you can find that specifically treat oral motor tremor and difficulty, especially even speech therapists may be a good choice, as well as dentists. So I know there are, like you could wear a mouth protector at night in order to help with sleep if you tend to grate your teeth. That's one thing. But the strategies are a little bit different, but it's probably similar in movement because your muscles work the same way in your face. But I'm afraid I can't really specifically address that for you tonight.
No problem. But another question about tremors, sort of a broader question. Is there a relationship between tremors and new lesions that may be forming? Is that oftentimes a sign of a new lesion?
So tremors can occur for a lot of different reasons, and I'm sure that a lot of symptoms, we don't know if they're evidence. I think anytime you experience a symptom is a good chance to go and discuss with your physician what symptoms have come up so that they can better assess, if something may have changed. A tremor and as ataxia, like we talked about today, they are usually from problems with the cerebellum, which is the region of the brain at the bottom and the back of the brain. Or pathways to that are what can cause it. So definitely a lesion could be a cause of a tremor and could be a reason for further having someone take a further look.
Great, thank you. A lot of the symptoms that both of you have been talking about this evening, obviously caused by MS, but can also be caused by age, just getting older, or other comorbidities or other causes. So how do you know if, for example, a walking issue or a tremor is caused by MS or caused by something else? I don't know, Sue, if maybe you wanted to start.
Yeah, again, getting the professional input, the physician may be able to tell you from an MRI that, oh, this lesion is most likely the cause of your foot drop. Physical therapist may be able to tell you that, oh, the spasticity is the cause for, this difficulty with walking. General aging, I think we all know you're going to slow down somewhat, both cardiovascularly, you may have some orthopedic problems. But if you're seeing drastic changes in your walking at any age, it's most likely due to some of the symptoms from MS. And again, that's a chance for you to seek more professional input on helping identify why you're having these increased difficulties walking and what can be done about it.
We also got a few questions just about physical therapy in general, and who better to ask than two PTs that are here. If someone's looking, considering seeing a PT, is it sort of a triage and they should go once they start seeing pain or start seeing an issue, or should PT be more preventative or maintenance and regular?
I'll start, Jen, and then you chime in. A lot of physicians, and I certainly agree with this, think that the moment you're diagnosed with MS, you should leave the neurologist's office, call and get an MS screening done, an MS evaluation. That will give you and your healthcare team a very good idea of where you are baseline. And from there, are you going to have some spells where you decline? Are you going to have some spells where you're doing better again? Very, very important for us, though, to see you early on. And then certainly anytime there's drastic changes, you should be in touch with a physical therapist. And please keep in mind that the MS diagnosis does not always mean, oh, I'm going to just go straight downhill physically the rest of my days. I've had some patients who say that MS is the best thing that happened to them. It got them healthy for the first time in their lives. Again, they may have had a terrible diet, been a couch potato, zero exercise, diagnosed with the MS, decided to fight the best that they can, fight for their health, and they've been doing quite well.
That's great.
Jen?
I agree. I think someone I work with, she's all about who's your PT. I think we all know who our physician is, but I think it's important just as well to have a person that you can access throughout your life that can help you with any sort of movement challenges that you come across. And there's always room to improve our overall fitness activity. So I think that that's another way that people can be helpful. You definitely don't want to wait until you have pain to miss out on a chance that you might be able to prevent something from happening and get that education that would be beneficial.
Also, the National MS Society has a program called the MS Navigator. You can call in. They have a database of physical therapists, occupation, the whole healthcare team in your area that should be well versed in MS.
Great. We'll talk more about those resources later. Thanks for bringing that up, Sue. I think we have time for maybe 2 more questions. We did get a question about the MS hug. Is that a motor symptom, or is that more of a sensory or neurological? And what maybe a couple tips for those that may be experiencing the MS hug?
Jen, I'm going to shoot that one to you
I
first.
was going to let you go ahead. I don't know. I think you might be better, actually.
The MS hug is a sensory problem, a sensation of tightness, a tight band around the bra area, coming from the spine, wrapping around. A lot of people have it. A lot of people do not have it. It comes and goes. It's not anything that's going to cause like a frozen shoulder or any, prolonged lumbar problem or upper extremity problem. It's a sensory come and go symptom that can be very, very annoying though, and kind of frightening. I know some people have confused it with a cardiac event, just like, oh, this sensation, is this going to grip my heart? Is it a heart attack coming on? It's it's an interesting kind of strange phenomena.
And I'm sure we'll talk more about that next week on our sensory symptom webinar. So last question, you offered a lot of really practical tips to manage some of these symptoms, but specifically with hand dexterity, any tips that you can offer to improve hand dexterity?
Sure. So I think first of all, it's one thing to kind of look out for what are your symptoms, because it could be a weakness, it could be a range of motion problem, or it could be a coordination issue. I'll just talk to one example, I think, of how some of the strategies I talked about tonight could be done with a college student who wanted to improve her typing skills. She actually wanted to be able to type her term papers directly, but we found that in order to improve her typing skills, she actually did better to do it more like in a typing class. So just to copy passages from like a newspaper article to start off and get that practice of typing, because the added ability of thinking on top of what you're doing can make it more difficult. And so I think practicing things that are easier, that you can do without needing to think about how you're doing them, and then progressively make things more challenging. That's the best way to go about something like that. There are also hand specialists in OT and physical therapy that can offer more specific guidelines, because the hands are actually very complex, and in order to do well, you want to be able to address that the best way possible. So I always send you back to someone local who can best help you out.
Yes.
And there are so many cool little gadgets that you might not be aware of at all that can be so helpful for what we call activities of daily living.